Hello. So yes, my remit is to talk about how we manage relapse and/or refractory myeloma. So what am I going to talk about? Well, I'm going to do a brief overview and describe what we actually mean by relapsed or refractory myeloma. We're talking about when we sort out the timing of when we start treatment and what factors we consider when a patient has relapsed and how we model treatment accordingly. And I'm going to talk about some of the various treatments that are currently available and funded under the NHS for relapsed and refractory myeloma. It'd be great if you could take 3 messages home from this. As Sophie has alluded to already, unfortunately, myeloma is still not a curable disease, and we therefore know that it will return at some point, even after prolonged remissions, which we all hope for. But it's actually very difficult to predict exactly when that will happen. And that's why patients are monitored in clinics and at home, and we're looking out for tests that we can do and symptoms that can help to identify relapse. And thankfully, there are now a lot of treatment options available for relapsed and refractory myeloma, and I'm going to talk about some of those. So, I'm very old in terms of hematology, consultant hematologist. So, when I started, the life expectancy of patients with myeloma, when I was a hematology registrar, was about 2 years, maybe. We now know that half of all myeloma patients will survive at least 5 years. And 1/3 of myeloma patients are now surviving more than 10 years. And that 5-year survival figure that I've quoted earlier does fit in with my anecdotal story that the 5-year survival has doubled since the 1990s. And the 10-year survival has actually tripled. So that's a good news story. The average life expectancy, as opposed to survival, has quadrupled. And things are improving all the time. This is a sort of in cartoon form of what relapsed myeloma is about. We're measuring the paraprotein, as a lot of you, I'm sure most of you know, and we see it going up at the time of relapse. A patient is retreated, and then they go into the remission and the plateau, then unfortunately may relapse again. And this is a refractory patient in whom, despite treatment, the paraprotein continues to go up. And we can talk a bit, I'm going to be talking a bit more about that later. And this is a more personalized patient view of what happens. As, again, a lot of you know, all myeloma is preceded by this thing called MGUS, or smoldering myeloma. The disease eventually requires treatment. The patient becomes symptomatic. And then it's a series of remissions and relapses, and onwards we go. Classically, later remissions are shorter than the first remission, although with some of these new drugs that are coming on, that may not be the case, that's one of the reasons for optimism now, although that's very much watch this space, but there is reason to be optimistic at this end of the graph. And why does myeloma relapse? So the top line explains in general terms. So like all cancer, myeloma involves a clone of abnormal cells, in our case, plasma cells. And these, untreated, they multiply. But the key thing is they're not static in their genetic makeup. They can develop new subclones as time goes on. And it's often the subclones that are the resistant ones. So the treatment successfully kills off these clones, but leaves this one, resistant. And it can still progress. So these are the guys we want to deal with at the time of relapse very often. So those of you who have been treated for myeloma know that either if you're on a sort of long-term maintenance type therapy, or if you've had treatment and that you're now being observed, you'll be coming to the clinic and having regular tests to show how active or otherwise the myeloma is. And some classic tests, the most simple and most non-invasive are blood tests, measuring the paraprotein, the light chains, also measuring blood count and kidney function. It's a way of estimating organ function. You may undergo from time to time more imaging, CT scans, MRI scans. We tend not to do that so much routinely, but certainly if a patient presents with new symptoms, we would probably want to do that. Or if the paraprotein or the light chains go up. And doctor or clinical nurse specialist will look at the trends. So a one-off result, it's a big mistake to get too excited about a one-off paraprotein that takes a bit of a jump. We look to see a trend before we absolutely decide that a patient is relapsing. And broadly speaking, there are two types of relapse. There's this one, the biochemical relapse, where the patient remains well and more or less symptom-free, but the paraprotein and the light chain, or the light chains, are going up. And perhaps more immediately concerning sort of relapse are the clinical relapse, where a patient has new symptoms, for example, new bone pain, in addition to the paraprotein and the light chain going up. Sometimes, very rarely, but sometimes the paraprotein, the light chains can stay pretty constant, but the patient develops new pain, perhaps from an isolated bone lesion. Very difficult to predict when a patient who's in a good remission will relapse. There are some factors that are influential here, though. Generally speaking, if you responded very well to treatment and you're in a very deep remission, that is going to delay relapse. Patients who are older and more frail and have other comorbidities, for reasons we don't always understand, may relapse earlier. And, you know, I was talking about those subclones earlier. If one of these subclones has got a particularly nasty chromosomal abnormality, then that will put you in a more high-risk group for relapsing. Now, a lot of these things, or most of these things, patients can't do an awful lot about. However, what the things patients can do is follow a healthy diet and lifestyle and try and keep as fit and mobile as possible. I think that's very important. And there's as we said, there's a lot of uncertainty related to this, which can be anxiety-inducing. So Myeloma UK have produced a very good webinar just dealing with that issue. So timing the moment of treatment can be difficult, as I was suggesting, particularly in the patient with the biochemical relapse rather than the clinical relapse. And it's got to be as a result of a discussion and with the patient and the healthcare professionals. But what we would be aiming to do if we retreat a patient at relapse is to control the myeloma, bring it back under control, and maintain a good quality of life. Bearing in mind that whatever drug or drugs that we introduce at that time may have their own side effects. So, you know, there's always a balance, and that's why timing is, you know, sometimes more of an art than a science in this situation. Not all patients with relapse will need immediate treatment, and this is particularly the people with biochemical relapse, because they're well, they haven't got any symptoms. Yes, the paraprotein may be inching its way up, but you can still, these patients can still be monitored, because in the early stages, we don't know if it's going to be a sort of slow, grumbling relapse or a more sharp relapse. So if the patient has no symptoms no evidence of organ damage, not anemic, and the paraprotein is rising slowly, then there is a very strong argument for just keeping the patient under close observation. You wouldn't have a sort of 3-month follow-up in this situation, more likely to be a month or 2 months, but there is an argument for doing that, very strong argument in my view. Right, a list. I'm not going to go through all of these regimens in detail or at all in some cases, and some of these names will be familiar to a lot of you. So these are the drug combinations that are funded under the NHS for first relapse, so in other words, second-line treatment. Okay? Some have been there on that list for a long time, some have only recently come on. Just thought I'd say something about second autologous stem cell transplants. My last bullet point may be the most important here because this was quite, I think this is going to be slightly, probably less widely used, less frequently used than in the past because of some of the new treatments that are coming online. However, I think it's still got its place, particularly if, a patient's had a prolonged remission after the first transplant and they're still fit and willing to undergo the treatment. Those of you who've been through a transplant know it's a pretty onerous process, and so asking you to go through it again is quite a big ask, to be honest. But we do find patients are fit and willing to do so. Obviously, you've got to have sufficient stored stem cells to be able to use them for the second time round. But still a valid treatment approach, although maybe used less frequently in the future. Now, this is very rarely used now, but I thought it was worth having a single slide about it. An allogeneic transplant. So this is, the transplant cells are from not your own, but are from a suitable matched donor, often a sibling, doesn't have to be a sibling. The group of patients for which this is now thought to be appropriate is very small. Young patient, the younger patients, if they've got other comorbidities maybe, and probably patients with these high-risk genetic abnormalities. My personal view is this is best done within the context of a clinical trial because the benefit for it is not clear, for allogeneic transplantation is not clear, although for selected cases it probably is a valid approach. Right, back to the lists. Third-line treatment, second relapse. As you will see, some of these treatments are purely oral tablets. Some involve subcutaneous injections or occasionally intravenous injections. And the actual choice of treatment is very much a team decision amongst the multidisciplinary team and, most importantly, with the patient. And fourth-line treatment here. Sophie's mentioned these, just very recently funded and had quite a lot of publicity. And I just wanted to say a little bit more about those. Some of you may know something about it, some bispecific antibodies already. The two drugs that are funded there, just approved by NICE very recently. And they're a form of immune therapy, and the cartoon shows it quite nicely. So here's the bispecific antibody, here's the myeloma cell, here's your own T cell, actual killer cell, and it brings the two cells together so it can attack, the T cell can attack the myeloma cell. And this treatment I can see becoming more widely used at fourth line in the months and years to come. You will have seen my list did not include another form of treatment that you may have heard or read about called CAR T cells. That's because I was restricting my list to treatments that are currently funded under the NHS. But people may want to ask about those in the question time. Refractory myeloma. So, remember the cartoon at the beginning? Patients who, despite treatment, the paraprotein is still going up. What can we do about that? Well, you can be on a combination of drugs and appear to be not responding, but we can increase the dose or some or all of the drugs in that combination. We can add in a new drug. So you're on 2 drugs, we can add a third drug. Drug that's classically used in that situation is a drug called cyclophosphamide. Or we can switch to a completely different type of drug. These combinations are quite intense and require inpatient care, but they can be, in a patient who's seemingly refractory, they can bring things under control in the short term and gives time then to introduce another treatment. These are very important. Clinical research in myeloma is very important, not only for drug development, but also for patients, because it gives patients access to drugs that they wouldn't otherwise have access to, that aren't yet, they're probably licensed, almost certainly licensed, but they're not yet funded for NHS care. So I'll just talk a little bit more about trials. Not everyone will be eligible for a clinical trial in this clinical situation. There are inclusion and exclusion criteria, and things that are taken into account are age, frailty, other medical conditions that might preclude them from being entered into the trial. These trials are often randomized, so you won't necessarily get the trial drug. There's put crudely, there's a toss of the coin, or there's an electronic toss of the coin. Half patients get the experimental trial drug, half patients get the standard drug. But even if you get the standard drug, you are getting the state-of-the-art treatment at that time, and sometimes some of these trials have crossovers so that if you're not doing so well on the standard treatment, you can be switched to the trial drug. Most people in clinical trials have to undergo more monitoring than they would otherwise do. That might mean more bone marrow tests, it might mean more scans, so that's something always to be aware of. And these trials tend only to be open at certain centres around the country, so you may have to travel. So although I've been stressing the benefits of clinical trials, there are potential downsides to being in one as well. And Clinical Trial Finder, very useful facility offered by Myeloma UK there. So how does it work? So the clever scientists in the laboratory design a new drug, then these drugs go into clinical trials, initially early phase trials just to make sure the dose is right and the drug isn't doing anything terrible to patients, then into these randomized trials that I've been talking about. If those go well, the drug is licensed, then it goes to a body like NICE in this country. Is it cost effective? Is it effective? And then finally, it gets to the clinic. So in clinical trials, if you go into one, you are sort of jumping a few steps, potentially. I wanted to say a bit about palliative care, and symptom control in myeloma is just about the most important thing in terms of a patient's quality of life. And that's where the palliative care team's expertise is so welcomed by myeloma doctors and nurses. As I say, not only do they have expertise about drugs that can help with symptoms, they also take a much more holistic approach than some of us do, I think it's fair to say, and they provide psychological and emotional support throughout the course of a patient's journey through having multiple myeloma. And they provide a lot of support for planning ahead. So I think it's very important that these teams are involved early in a patient's care. there is a great psychological impact on a patient when they're told they're relapsing. Of course, it's very disappointing and upsetting, and for some patients, that news is harder than being told the initial diagnosis. And from our point of view, no one likes giving bad news, and it's not easy sometimes for healthcare professionals to give that news, but it is important we are honest with patients, I think, at all times. In terms of coping mechanisms, of course, there's no right or wrong way to feel in this situation. It's quite likely your feelings will change from day to day, but I think it's very important that you talk to people close to you, the support groups, the info line or a peer buddy if you've got one. You can have more structured support from a counsellor, and we always encourage patients to continue with activities that they enjoy if they feel able to do so. And there's mindfulness, meditation, not for everybody, but I know some patients find it very helpful. And if you are struggling, please talk to your healthcare team about that. And you should be quite forceful in asking for help if you don't think it's forthcoming at first. So there are lots of people around who understand what you're going through, and we've talked about them before. Sophie's talked about them, the support groups, peer buddying, and online discussion. There's lots of information out there, again, via Myeloma UK, lots of services, and a very user-friendly website in my view, so do use them if you need them. So, just a quote there from a patient that's in the Small Things That Make a Difference booklet. Just a summary there of some of the resources. So it's not all online. There's the hard copy paper things as well, which if you prefer getting information in that way. Okay, a bit more stuff. So what have I talked about? I hope you've got a feel of how and why myeloma relapses. Sometimes difficult decisions involved in timing treatment when a patient relapses. Sometimes it's glaringly obvious when it's necessary, sometimes it's not obvious at all. And I've talked about some of the treatments, the wide variety of treatments that are now available for relapsed and refractory myeloma. And just to go back to the take-home messages, myeloma will come back at some time. Very difficult to predict. Ongoing monitoring is so important. The blood tests help us identify relapse, patient's symptoms, and never be shy about coming forward with new symptoms that you're worried about. And then third message was about the treatment options that are available. So, thank you very much. That's all I wanted to say. I'm very happy to answer some questions. So, if you would like to ask a question, we've got team members with microphones walking around. Hello.
Yeah, you mentioned on the first relapse that the possibility was for a stem cell transplant again, and if the cells have been stored long enough. What is the storage time for cells? Because I've been in remission now for 9 years. It's my stem cell transplant. If I go into relapse, will my stem cells still be stored? Do you know that?
That varies on the labs at the different centres. I would not. I think you should ask them directly, to be quite honest. Different labs will have different policies. You've clearly done very well after your first transplant, but the storage facilities in a lot of centres are quite large, but there will be individual policies at different centres, so I wouldn't like to say for sure.
I don't know whether you can help me with this question. My husband got diagnosed 9 years ago, and he's had 7 cycles, so he seems to go about 12 to 18 months, and then he relapses and relapses. At the moment, the myeloma's not too bad. The problem is he keeps getting chest infections. He's in hospital now as we speak, and this is his 4th admittance this year. He had 3 last year. Any ideas why? I mean, they say the myeloma is behaving quite well because he's on Velcade and dexamethasone once a week.
Yeah.
But it's just the chest infections. They're absolutely,
I'm sorry to hear that. Yeah, myeloma itself, by its nature, is an immune suppressive drug. So even patients who are in a quite good remission or in a very good remission even, are more immune suppressed than an average member of the population, so that they remain more prone to infections. So it's very important to be aware of that from the healthcare team and to treat infections early and quite aggressively. There are things that can be done in addition. Some patients are on prophylactic antibiotics even when they're off treatment. So you'll all be familiar, or many of you will be familiar with the sort of supportive medication that you tend to take while you're on treatment, but there are additional antibiotics that may be better for chest infections. And then additionally, some patients are suitable for intravenous immunoglobulin, people who are clearly very immune suppressed and who are getting lots of infections. It's a bit of a faff. It means coming in for an infusion of immunoglobulin every 4 weeks, but there's no doubt for some patients it's beneficial. But that tends to be the final step in prevention. Usually the first step is going on to an additional preventative antibiotic. But overall, the feature of myeloma is immune suppression and being less able to cope with infection than people who don't have myeloma.
Hi. You mentioned earlier on that with a biochemical gradual relapse, you wouldn't necessarily treat, and there's good arguments not to treat. What are the benefits of withholding that treatment, and are there any effects on the long-term outcome?
The benefits are being longer off treatment. People, for a very understandable reason, people don't like being on treatment. The downsides are the psychological effect of knowing you've relapsed and then thinking, well, why aren't they doing anything about it? This so-called we call it watch and wait, but it's also been known as watch and worry. So you've got, oh, hello, my paraprotein's gone up 2 grams. Why aren't they doing anything? Well, I hope I explained the reasons why, because that period can go on for a long time, and that could be a long time, adds to a long time off treatment. But I think what you're alluding to, I think, is quite important. What we mustn't miss is sort of hanging on too long, and then something more dramatic happens, like a new nasty bone lesion or the kidneys deteriorating. So I stress that patients in that situation should be monitored closely in the myeloma clinics. And some of patients in that situation we're seeing every 4 weeks. 8 weeks may be appropriate, but I'd be very reticent about leaving longer gaps than that between appointments for someone who's in early biochemical relapse without any symptoms.
Good morning. Yesterday afternoon, my clinical nurse specialist told me that I was just about to possibly start a relapse, which was a bit of a surprise, but singularly appropriate for today. Is the relapse stage the point when it's appropriate to introduce a FISH test equivalent to check that there's been no translocational issues relating to the new clonal plasma, clonal cells, because bearing in mind that translocational issues are very important, they must happen at some time. So when is the time to be investigating this? And is a relapse or refractory point the time to do it?
I think that's a very good question. As it happens, I'm on the writing group for the British Society of Haematology guidelines for management of relapsed myeloma. They're not published yet. They're still going through the various drafts. We are going to recommend that sort of testing should be done at relapse, certainly at first relapse. However, that will be a guideline. These are expensive tests, and locally, it'll be local decisions about whether they can do them, whether it's sufficient funding to do those chromosomal tests. I know in some centres they do, around the UK, some centres they don't. It could be argued that because of the nice funding regimen, it might, at this stage, might not make any difference to what treatment you actually get, whether you've got a new translocation or not, because we're a bit limited in treatments. However, I'm a believer in thinking, well, all information like that is good, because it at least may give some useful prognostic information to the patient. So I'm with you, I agree, but it may not be what practice around the country or where you are. It may be, it may not.
Hi, I just wondered if you're in the paraproteins are undetectable, and then there was a couple of months where they've gone up, and then they've gone back to undetectable again. Like from what you've known over the years, what is the chance of them staying undetectable again for a long time? It's just I just found it quite confusing that they'd appeared and now they've disappeared again, and it's just I've been told, you know, not to worry, you know, and trying not to, but I just wondered.
Well, it's interesting that, isn't it? We do see that in the clinic sometimes. I mean, I think that just emphasises the point why we should not get too focused on one result that it pops up and then it goes back down again. So what could be happening? Well, it could be that the disease is there just at a very, very low level, and it just sort of, at that time of the blood test, it just sort of peaked up a bit, and the paraprotein became detectable, then it became suppressed again. I don't know if you're on ongoing sort of maintenance type treatment, and that may be a feature of what happens in that situation. So I suppose it's an argument for why so many patients are on maintenance treatment now. It's just keeping everything under good control. But no, I'm delighted it went down again, and I think it just shows the importance of looking at trends rather than isolated paraprotein results.
Thank you. For patients who are non-secretory or oligosecretory, often they need to start treatment because of clinical signs.
Yes.
When options are running out, but they can't access clinical trials, what's next for them?
Right, so just to explain what we mean by oligosecretory. So these are this rare group of patients who have myeloma but don't have detectable paraproteins or light chains in the blood. So in terms of following them up, it's harder. These are the patients who tend to have scans more often, particularly if they've had bone disease in the past. Yes, it is very unfortunate that it tends to be an exclusion criteria for most, if not all, clinical trials, because clinical trials like to have a measurable paraprotein or light chain. It's very difficult. I think we just have to pursue everything that is available at the time under the NHS. But I do think it's slightly, I mean, I don't say unfair, because the trials have got to be created in a way that they can produce meaningful results, but it is tough on the patients who don't produce paraproteins with their myeloma, that they're excluded from a lot of trials. Got one? Oh, no.
Yeah, the practice at my local hospital seems to be to take your blood tests for your consultant appointment on the same day as the appointment, with the idea that they're available for the next one 2 months later. Now, Patient Knows Best allows us to look at what's happening with the levels of the blood results. I'd like your advice, please, what to do if there really seems to be a significant spike in what would be a clinical relapse with an organ, rather than, in the case I'm talking about, light chain levels. So there's a spike in the kidney function, really quite high, I think. but it's like a long time until 6 weeks or so till the next appointment. Do you contact the hospital, or do you just say?
Yeah, well, if you're concerned, I think you should ring your team just to make sure they haven't missed it if there's been a deterioration. I mean, the point you make about being bled on the day, for patients who are off treatment, whether they've got sort of smouldering myeloma or if they're on sort of monitoring between treatments, I tend to like them to be bled a week or two in advance of the clinic appointment. It does mean 2 visits, but in that way we've got the most up-to-date paraprotein result when we actually see the patient. So, well, that's the way we like to do it anyway. But yeah, so more patients do have access to hospital results now through apps and other means. If you are concerned that anyone that their kidney function has deteriorated and it might have been missed, and these things do get missed, we get results coming at us all day, every day at work. So do contact a clinical nurse specialist or one of the team.
Good morning, and thank you so much for the opportunity to ask questions.
Pleasure. Where are you?
I'm here.
Oh, there you are.
My husband's about to have his first stem cell transplant, and we understand that that's got the longest chance of remission.
Yes.
And his question is, he's been suggested to have consolidation treatment,
yes.
and he wants to know scientifically how that prolongs and deepens remission, because that seems to be quite a new thing.
It is new, but it's based on very sound clinical trial evidence, I'm pleased to say. So that what you've just described now is universal best practice across the UK. So until 3-4 years ago, I can't remember when lenalidomide maintenance was first approved, maybe not that long. So patients used to have a transplant, and that was it. Then clinical trial evidence showed there's benefit of patients going on maintenance with the oral drug lenalidomide after transplants, and that became practice. And then another clinical trials, or more clinical trials, have shown that in addition to that lenalidomide maintenance, if you have a couple of cycles of consolidation treatment after the transplant, that also confers a benefit. And that's why we do it. Yes, it's more for a patient to go through, but generally it's the same treatment as they had prior to the transplant, same combination of drugs. So if they cope well with that, they should be able to cope well after the transplant, after a suitable period, recovery time after the transplant. I think I should stress that, it's not 1 week after the transplant, you're bang, you're on consolidation. You've got to have some recovery time and then start.
Two questions, if I may.
Well, I said at first one, but we can come back to you.
Okay.
Okay.
What's the rationale, please, for leaving the use of bispecific antibodies until late in the development of the disease rather than earlier?
Good question. Clinical trial evidence. So there are clinical trials now that are using bispecifics much earlier in the process. So NICE will not look at funding anything that's not got really good clinical evidence. So the evidence out there, published, is that in relapsed or refractory myeloma, bispecifics are very effective, and that's why they've gone into fourth line. With time and more evidence, we may see that moving them up front or second line or whatever has benefit, and then the drug companies will go back to NICE and say, look at this, why aren't we funding this? So at the moment, that's why it is.
And the other thing, if I may, was what are the benefits of MRD testing?
Right, very good question. MRD, or I should explain to everyone, so MRD is minimal residual disease. So that is disease at a very low level, at the lowest detectable level after a treatment. So you can be in complete remission, no paraprotein, light chains normal, bone marrow normal, but there may still be some disease around at the very lowest detectable level. And I think it's well established now that if you are MRD negative, i.e. there's no detectable disease at the lowest possible detectable level, that has a better prognosis than being MRD positive. Very interesting, very useful. At the moment, that fact is not altering treatment. Will it in the future? I think quite likely. But again, very expensive tests. Are we going to do them for all myeloma patients? Are we going to do them for selected myeloma patients? A lot of difficult questions. But all clinical trials now are really looking at, just about all of them are looking at MRD. So that just shows you what an important marker of disease activity it is. I've got one down here. While you're going with the microphone, I've got one written question, which thank you for whoever submitted it. Are the signs or symptoms of a relapse likely to be similar to the symptoms experienced at diagnosis? And I think the answer to that is yes. Patients who present with severe kidney disease often relapse with severe kidney disease. Patients who present with bone disease and pain are more likely to relapse with bone disease and pain. It's not universal, but I think in general terms that is true. So for example, if we've got patients who presented with severe kidney impairment, we watch them very closely, their kidney function in clinic. We're also looking at their light chains, because it's the light chains that tend to do the most damage to the kidneys. So we might have a different threshold for starting one of those patients on treatment than we would for someone who didn't have kidney disease at diagnosis. So I think that's quite a salient point, whoever asked that.
Hello. So my mom lives in the Czech Republic, and she's been diagnosed last year. She's doing really well. She had her stem cells transplant, and her light chains are normal.
Good.
All the blood results are normal. However, her paraprotein is still at 5. Mm-hmm. It's been like that maybe for the past 3 months. It's just not changing. But otherwise, she's feeling basically like a healthy person. And I'm just wondering for how long you think she should be continue taking the lenalidomide for, if everything stays the same?
Well, I won't comment on her individual case, because that would be a mistake. But I think we are keeping patients on lenalidomide maintenance for as long as it's working, or as long as the patient's being kept in remission and the disease is being suppressed. So there are arguments about when it should be stopped. And back to MRD, could that decision be based on MRD? Could we stop lenalidomide maintenance for a certain group of patients? But we're not at the moment. So in general terms, anyone who's on lenalidomide maintenance after a transplant will remain on it, providing they're tolerating it and it's not causing bad side effects, of course, for as long as the patient's in remission, and then only stopping the lenalidomide when the patient clearly has relapsed. One? We've got time, yeah.
Dr. Stern?
Hello.
Sorry, I'm at the back.
Hello.
It may be too soon to know the answer to this question, but if a patient has been on a bispecific treatment, then relapses, does that limit them from going on a different bispecific in the future?
Not necessarily, and certainly not in a clinical trial, because there's some bispecifics attack different sites on the myeloma cell. The only 2 that are funded, the 2 that I listed, go for the same site. So you couldn't go from one of those to the other one of those at the moment. If one of these newer bispecifics that attack a different site on the myeloma cell, in theory, you could go and be treated with that one. But of course, we wait to see whether NICE approve that line of treatment. So theoretically, yes. Clinical trials that look at another, you could go into a clinical trial that with one of these bispecifics that attack a different site on the myeloma cell. But at the moment, under the NHS, those newer bispecifics, if for want of a better word, are not yet available.
Hello. Going back to lenalidomide.
Yes.
Why is it that patients who've perhaps had it as frontline treatment at full dose then can't necessarily tolerate it at a much lower dose as maintenance?
After transplant?
After transplant.
Well, it may well be to do with the, I suppose, delayed toxicity of the transplant itself. Remember, the transplant involves high-dose chemotherapy, usually with melphalan, almost always with melphalan, and that has an effect on the bone marrow. So, particularly in terms of lenalidomide, which can suppress the blood counts, you may not be able to tolerate the same dose of lenalidomide after transplant as you did before the transplant, because the bone marrow is just not quite in such a healthy state. And I think that's very important, and that's why the lenalidomide dose is designed to be relatively low, but it's still effective at a low dose, which is the most important thing. But yes, it may have a lot to do with the sort of delayed effect of stem cell transplant, which is why when I was talking about second stem cell transplants earlier, that's always something to bear in mind. What effect will it have on the bone marrow after the second stem cell transplant, which is what double dose melphalan, if you like. Perhaps if I could, I think this would be a good question to finish on because it's very appropriate, and it's another written question, and it's, at what point do patients stop being offered treatment, and how much control does the patient have to stop the treatment themselves? And that's a very, in many ways, emotive question, but I think the most important thing to say is the patient must have the ultimate must be the ultimate decision maker there. It should be a team decision, a team discussion, the potential benefits versus the downsides of treatment. But when patients are on sort of fifth, maybe sixth line treatment, there is a sort of law of diminishing returns to an extent that there may be some benefit from a drug or perhaps a clinical trial, but there may not be, it may not be so successful. So I think honesty is very important, but I think the patient absolutely should have the final say. Okay, I think we've had a good session, a good question and answer session, so I'm going to leave it at that, if I may, and you now have a refreshment break. About 45 minutes, so but I will be about all day. If anybody wants to corner me or ask me things, please feel free to do so. So we're coming back here at 11:15. Thank you.